We've got 80 of you on. We've got over 300 people registered, which is really fantastic. So thanks for giving up a Saturday and coming along. I guess it's reflective of the panel that we've got today that we're very lucky to have. I'm Chris Twine, I'm a vascular surgeon. I don't have a venous interest, which is why Steve Black is co-chairing with me, who's an internationally renowned venous vascular surgeon and deep venous expert. And we have a great faculty today who I'll come back to in a minute. Before we do that, there are just some notices. The first thing to say is that BSET would like to thank Medtronic, who sponsored this session. Thank you very much for doing that. We can't run things like this without sponsors. A couple of BSET related notices. We've got an upcoming webinar, same as this, on Saturday the 19th of June. That one is going to be strategies for reducing the iatrogenic vascular injury. It's the same deal, short webinar, should be really good. And importantly, we are running the BSET meeting this year just as an online half day. That's going to be on the 24th of June. We're running it for half a day because I think we all recognise that we're all getting a bit sick of these online conferences. So we've packed in as much as we possibly can. We've got great international faculty. We've got abstract sessions. We've got everything you'd expect from the BSET meeting, but just condensed into an afternoon. So please come along to that if you can. So the panel we've got today, we've got four speakers who've given up their time on for Saturday. Thank you very much for coming to do that. In order that they're going to present, we've got Manj Gohel. Manj is a vascular surgeon in the UK and a venous expert. He's recently co-chaired the ESVS venous thrombosis disease guidelines, which I would recommend you all have a look at if you haven't already. They're really good. And you've probably seen him going on about the EVRA trial a bit in the last couple of years. We've got Erin Murphy, who's a venous vascular surgeon based in Charlottesville in the USA. Thanks very much for coming, dialing in from the States for us. She's director of the venous and lymphatic program over there. So looking forward to an international perspective on cases. We've got Michael Lichtenberg, who I'm sure most of you have seen talk before. He's an interventional cardiologist and angiologist in Germany. And he's got a name as a complex endovascular interventionalist. So again, he'll have some great cases. And we also have Hayley Moore. She's another vascular surgeon. She's currently working with Steve in London, but I think she's about to move units. So we're looking forward to those. I think they're going to be great. So the first thing we're going to do is start with a poll. Jeanette, can you take this over now and run this if I stop sharing my screen? Very good. So for everyone that's on now, hopefully you should be able to see this poll. In my unit at present, it's the care for patients with proximal acute DVT. There you go. If you can just fill this in over the next few seconds, and then we'll talk it through, and we've got some responses. Only catheter-directed thrombolysis available, both catheter and rapid thrombus removal systems. We treat them conservatively, and only pharmacomechanical. And we've got people who are dialing in from all over the world, so actually this will vary probably quite a lot depending on where you're joining from. So we're probably pushing towards the majority here being both catheter-directed thrombolysis and rapid thrombus removal systems, which certainly would be my experience. Steve, what are your thoughts?
Yeah, I think, I mean, we're going to get a lot out of the speakers today, but having different options for treating patients at different stages of disease or presenting with varying risk factors for lytic or needing lytic, I think is helpful. So I'm interested to see the second answer is probably what I would instinctively agree with, actually.
Yeah, I'd have thought that would have been the most popular. International faculty, is this, I mean, I don't want to obviously ruin what you're about to say in your talks, but is this the sort of thing that you'd have expected, or do you feel very differently about it?
I'm happy to start, guys. So what's interesting is that obviously there's a selected audience and a population. So actually, if you look internationally, a lot of people are managing these patients with anticoagulation only conservatively. So we have to recognize this as a sub-selected audience, but I agree. I think with the technology available now, having both a CDT option, but also some sort of pharmacomechanical, but also thrombectomy alone. So these are all exciting options. So I agree with option 2.
That's great. Well, look, Manj, being as you're already talking, without further ado, should we head into your talk?
Fantastic. Okay, can you see that slide? A quick nod would be helpful. Fantastic. So first of all, I'd like to express my gratitude to BSET and the organisers for the kind invitation. It's a real honour to be part of this faculty. The group on this virtual podium are people I hold in very high regard. So I see my job really, we're going to talk a lot about the how today in the other presentations, I suspect, but I'm going to just take it back a level. I'm going to start talking a bit about the reasons why we would suggest early thrombus removal, but also whether we should do it or not. So this is a step back from how. Until we realize why and until we decide, whether it's the right thing to do, the how is really the third question to ask. These are some disclosures. So here lies the problem, as is the case with many current issues and many political topics at the moment. We have a pretty partisan binary position. We have enthusiastic advocates where early thrombus removal is the norm. Every patient with an femoral DVT, unless there's a really good reason not to, should have early thrombus removal. We have the naysayers, the people say the evidence doesn't really support it, so we really shouldn't be doing these expensive and invasive interventions. And again, I'll declare my position right at the beginning. So can you guys see this gap in between these two positions? Well, I'm wedged firmly in that gap. I'm getting splinters from both sides here, trying to work out what is the right thing to do on an individual case basis. And some of the topics that I'll bring up and I'll discuss will make it clear why I think this is really not a clear-cut topic. And there's a lot more work we need to do to really understand the right thing to do for the right people. So as again, I'm sure we're going to hear during the course of this event, there are many, many different ways that we can remove thrombus. And I'm not going to go into this. I'm going to focus on the whys and the overall strategic decision-making for the decision whether or not we should go for early thrombus removal. The nuances and the techniques are, another 4 hours of discussion in themselves. But really just to emphasize, there are now a range of things, not just the standard CDT with a multi-site hole catheter, but all sorts of pharmacomechanical options, of course, open surgical options, but also total thrombectomy with no lytic at all. So it's a really exciting space from a technology perspective, but we've still got some fundamental questions to answer. And what I'm going to try and cover briefly, I promise, are these sort of main areas. Why are we even talking about this? What's the rationale? I will summarize the available evidence. I'll talk a bit about the guidelines. I'll show you a couple of cases to show maybe why I'm slightly torn and split on this, and give you a few personal perspectives, really for food for thought. Okay, so let's start with the case. So this is a case I treated, I think 6 or 7 years ago now. A 17-year-old female patient, entirely fit and well, who presented with an unprovoked left leg iliofemoral DVT. And again, I'll just show you a CT because we all like looking at pictures, and you can see a large distended edematous left iliac vein. And just look at the extent of the edema and the swelling in the left leg. So the decision at that point was made to treat her with early thrombus removal. She was very symptomatic. She was very keen for intervention. And she had some thrombolysis. And after 36 hours or so, there was good thrombus clearance. She had a stent of what looked like a tight May-Turner lesion. And this was her most recent scan, 6 years later. So she's entirely symptom-free. It was an unprovoked DVT, so she's on a low dose of rivaroxaban. She has a widely patent iliac venous system, and she runs half marathons. And she loves us. She thinks that we've done her a really good service. And you see a case like this, and you sometimes wonder why we don't do this for everybody. It is clear that in early thrombus removal with appropriate treatment of an underlying iliac venous problem, you can get excellent results like this patient. I'm going to show you a couple of cases later on that show the slight counter, but this is the reason why we're even having this conversation. And again, it's worth just reminding ourselves, why would you even consider doing this? Well, clearly there is this idea of preventing this mystery long-term condition of post-thrombotic syndrome. But I think there are a couple of almost even more important reasons we do this. The rapid improvement of symptoms I think is really, really important. Even if we say at 6 months or a year, people are going to end up the same. The journey for somebody who is recovering very slowly with the impact on their quality of life and their work is going to be much more miserable than somebody who recovers within a day or two. And of course, overall, we want to improve people's quality of life. So this is the rationale. And again, you have a case like I've just shown you, and you can see why people really want to do this and are very enthusiastic about it. Let's talk about the evidence. So very recently, there was a Cochrane review, very well-respected system for evaluating the available published evidence. And I'm not going to go through it in detail. I will just show you the summary slide. So there were some issues with this review. They've included a large number of historic studies, including studies of systemic thrombolysis, which clearly is something we wouldn't use at the moment. But I think there are some themes here which are fairly consistent with the modern study. So I'll just point those out to you very briefly. Unsurprisingly, if you treat with thrombolysis, you're more likely to clear the thrombus. It's not great though, but you're more likely to clear the thrombus. Unsurprisingly, with thrombolysis, the bleeding risk is higher. And again, unsurprisingly, with thrombus removal, there is a lower risk of post-thrombotic syndrome. But again, the theme is that the results are not overwhelmingly positive. The benefits are not so great that you would think this is something we absolutely have to do. But these are the themes from this Cochrane review. And again, I'll go on to some other evidence that also shows us some more contemporary data. So Chris very kindly mentioned the ESVS guidelines. I had the privilege of being the co-chair of these guidelines along with Stavros Kakos. And this was a really fantastic experience. It's a process involves gathering together thrombosis experts from around Europe, of a whole range of specialities and countries. This is a picture of the group before COVID. And one of the areas we looked at in quite a lot of detail was the idea of early thrombus removal. The guidelines are dedicated to Clive Kieran, who was one of our very sort of diligent reviewers who sadly passed away before these guidelines were published. And in the guidelines, the process involved looking at the relevant published randomized trials to help guide recommendations and guide practice. And I've put the sort of the main studies that were looked at. And of course, we will have heard of these studies. The Cavant study from Norway, recruited in 2006 to 2009, the ATTRACT trial, and the CAVA trial are the three main randomized trials. There's one more slightly historic trial, which is the Torpedo trial. But these are the main studies that have been done in this area. And I will just mention them very briefly, just so we've got an understanding of the foundations of our evidence base. So the Cavant study was the first sort of sizable study that was done. Per Morten Sandset was the chief investigator in Norway. And they randomized 209 patients with proximal DVT. And it was essentially anticoagulation alone versus anticoagulation plus CDT. Only around 40% of these patients had ephemeral DVT, and although the primary outcomes were patency and PTS at 2 years, they looked up to 5 years. And again, these were the 5-year data. So you can see along the top line here, the incidence of post-thrombotic syndrome at 5 years was significantly lower in those patients that received adjuvant CDT, which was highly statistically significant. But again, there are a few points to make here. The patency, despite adjunctive CDT, I mean, the whole point of thrombus removal is to restore an open vein, was actually fairly disappointing. Only around 80% or 79% of people had patent veins. And what was also interesting was that those people treated anticoagulation alone, over 70% of those had patent veins. So again, just raising a question as to the natural history of this condition, how many people are going to do okay anyway, versus the challenges about getting a good technical result when we do decide to intervene on these people. And also importantly, the 5-year quality of life was no different in these patients. So it's been a struggle to demonstrate quality of life advantages, even if there have been some PTS advantages seen based on the Villalta score. Okay, what about the ATTRACT trial? So I'm sure we will all have heard of this trial. This was a very large NIH-funded study, the largest randomized trial in this space, and a real labor of love for the investigators who were at this for many years. So 692 patients were randomized, and again, this was a slightly more modern trial in that it wasn't just CDT, but also some pharmacomechanical Devices were also offered, 57% on iliofemoral DVT, and the primary outcome measure was PTS as measured by the Bellalta score. And again, we'll all be familiar with the main outcomes, the headline figures, which were that there was no difference in PTS rates between the thrombolysis group and the control group. Now, they separately published results from the iliofemoral subgroup. Now, this was a 391 patients that had iliofemoral DVT, and here the results were a little bit more persuasive. If we look, for example, at moderate to severe PTS, there was a statistically significant reduction in moderate to severe PTS in the patients that had adjunctive thrombus removal strategies. But again, as with the previous evidence, the benefit was not overwhelming. Indeed, we'd have to treat 196 patients to prevent 19 from developing moderate to severe PTS. Now, there are plenty of conditions that we treat surgically, carotid disease, aortic disease, where the number needed to treat is higher than this. So I'm not dismissing interventions, but I suppose that the question I'm raising with some of these evidence, some of these data are, is the strength of feeling that is held in some quarters really justified based on the available randomized evidence that we have? Now, they did a subgroup analysis, and again, this is really getting to some of the real nuances of what we need to try and work towards, which is which subgroups are most likely to benefit from intervention. And again, there were some hints to prevent subgroup with the age less than 65 seem to have a potential benefit. Those with a major risk factor, i.e. a provoked DVT, seem to have an advantage. And so all of these factors we need to think about when we're trying to decide whether or not we should be thinking about interventions. I will very briefly mention the CAVA trial. So this was a Dutch study, and in summary, this was only iliofemoral DVT, but there was no significant difference in the two groups. So again, didn't demonstrate, even though we only looked at iliofemoral DVT, didn't demonstrate the sort of advantages that perhaps enthusiasts, including myself, would expect to see in this subgroup. So I don't want to bash the investigators of these trials too much. I'm a clinical trialist. It is a labor of love trying to do big multi-center randomized trials. And there have been lots of personal sacrifices, not least sanity and time and friendships in doing these trials. But we have to recognize that there are inherent flaws and some difficulties in the evidence that we do have available to us. And probably the biggest is the one at the top, the selection or inclusion bias. And we have to remember that the only people who would have been entered in for randomization are those that the treating physicians would have had some sort of equipoise for withholding thrombus removal, because that would have been a 50-50 chance. And so a lot of patients with more severe presentations may have never made it into these trials. I think the second one is also very important, the poor technical success in these trials is apparent. Very low rates of stenting, significantly under 40% or close to zero in some of the trials. And I think we have to recognize that, yes, they give us an indication, but they certainly don't give us the major answers. Now, in terms of the ESVS guidelines, we did look at and meta-analyze some of these trials. And again, the themes are going to be very familiar to you. If we look at all PTS, then there is a hint that early thrombus removal is favorable, but the confidence interval touches 1. It is not compelling, and the benefit is really borderline. If we look at moderate to severe PTS, it's a little bit more persuasive. And it does look like there is a benefit for reducing the risk of moderate to severe PTS, but there's of course a downside, which is the bleeding risk. A significant increase in bleeding risk associated with these early thrombus removal techniques, particularly those involving lytics. So we have this really difficult balance to try and negotiate and try and make sense of when we decide how to treat our patients. So how do we get around this in the guidelines? With some difficulty and considerable debate, but this is what we came up with. And I think what was clear was that for infrainguinal DVT, there is clear evidence that early thrombus removal doesn't really help this group. And in fact, with the bleeding risk, there's potential evidence for harm. So we were fairly comfortable in saying that these people shouldn't be treated with early thrombus removal, except in perhaps extreme cases. But for people with iliofemoral DVT, it's clear that some people do benefit. I mean, the case I showed you right at the beginning has had a very good outcome. And so we have this, this positive recommendation saying that selected patients should be treated. Of course, that doesn't really take us that far forward, because what do we mean by selected? Well, I think we have to be sensible. And you know, if we are borderline about the interventions that we're going to offer, we should be looking at people that we think is at the highest risk of PTS, those where we can offer a highly technically successful procedure to do what we want to do, i.e. remove thrombus, but also with very low risks of complications. And I think this is where the discussion needs to go forward. We need to work out how we can achieve these things to get the best possible outcomes. So again, I won't go through the guidelines, but to commend them to you and to say that actually early thrombus removal is suggested at an early stage with low risk bleeding groups with iliofemoral DVT. I am sure we are going to go into some of these outstanding questions. And for me, the single biggest question is which are the subgroups that are going to most benefit? Clearly some do. I'm pretty certain that quite a lot don't. And we have this real, this paradox between an undoubted undertreatment. There are undoubtedly people who are not getting the thrombus removal treatment they should, with at the same time an overtreatment of some people who probably would be absolutely fine with conservative management. Once we've decided who we should be treating, what's the optimum strategy, and then the stenting strategy. And in the guidelines, in view of the lack of evidence, the only way around this was to really leave this to the treating physician, assuming that local audit and local governance processes are in place. So I'll just show you a quick case just to give you the slight counter and give you some of my apprehensions about a really aggressive approach here. So this is another patient, more recent, 20-year-old university student, very fit and well. She was on the estrogen containing birth control pill. She presented with a fairly typical back pain, which is often the first presenting feature of an iliofemoral DVT, followed by the leg pain. And despite 3 or 4 days of conservative management, she could only walk 4 or 5 yards. So it was clearly very disabled. And again, a CT demonstrating an edematous, thrombosed left iliac vein. Now, she underwent early thrombus removal. So these are the pre-images. And you can see on this venogram, the wire just getting coiled up at the proximal common iliac vein, really indicating a potential technical issue there. She had CDT. This is after thrombolysis, where there was some improvement, a technical issue at the May Turner point, and she underwent a really good improvement in her symptoms. So our protocol is, again, very similar to some other departments. She had a check duplex on 24 hours, which looked very good, discharged with low molecular weight heparin and antiplatelets with compression, with a plan to rescan in 2 weeks' time. And she came back for her rescan in 2 weeks, and this is what her scan looked like. Thrombosed inflow, thrombose stent. We tried lysis, and there was a real resilience to this thrombus. This wasn't just a day or two old. So we struggled and we couldn't get this open. What was really interesting is that her symptoms were significantly better than they were the first time round, where there was a similar pattern of occlusive disease. So again, there's a lot we don't understand about these patients. Now, she's subsequently been found to have triple positive antiphospholipid syndrome, which is, I accept, is bad luck and a very difficult patient population. But she also has a stent that I know is going to be very, very difficult to recanalize and open in the future. But again, what's interesting is at 2 months, she's able to walk 2 miles with very little in the way of symptoms. So again, it raises the entire question of, did she need anything doing at all at the beginning? So a real dilemma and head scratching over a case like this. And just one final comment about the role of stenting. Now, I am convinced that if we are going to have an aggressive approach, that actually more stenting than is in the trials is almost certainly going to be needed, because leaving the underlying scarring and stenotic disease will lead to early rethrombosis. But this is a challenge with the stenting. So this is a chronic patient with severe PTS who we treated, and stenting had a very good result. At 2 years, she had some in-stent narrowing, which was symptomatic. So she had a venoplasty alone, which again improved things. However, a year later, she had a recurrence. This time we relined, and again on IVUS, very good technical results. We actually thought there was maybe a little bit of disease that we missed the first time around, so we thought we've dealt with that now with a relining, nice open stent, and again very good symptom relief. And a year after this, she's got more of this in-stent thrombus lining. And the problem with having to stent, which I think is what you have to do, is you end up every so often in this sort of situation where you have got to maintain very, very close follow-up in these patients to avoid these stents going down. So our algorithm is very briefly like this. Everybody who we are considering intervention for is admitted, aggressive elevation, compression, good anticoagulation. And I would say almost the default is along the conservative path, because we've got quite a lot of confidence in our ability to deal with PTS down the line. I accept that in some cases you might lose an opportunity. But clearly, if the symptoms are very severe, then they are considered for early thrombus removal. But that's really for discussion. A couple of things I'm sure will come up. So one of the big questions that people ask is, are the poor results or relatively poor results in the published studies down to an inadequate technical results and technical outcomes from the intervention? And there may be an element of truth in this. So the CLEAR DVT study, again, Steve Black and Mitch Silver are the PIs for this. I'm sure we'll discuss it. There's a real focus on technical success. And is there an improvement if you actually get all the technical success right? So that'd be interesting to hear. And I think the second comment I'd make is really about this pressure that there is to deal with thrombus within the first couple of weeks. It's very difficult to predict in that period, in my experience, who is going to develop severe post-thrombotic syndrome. It would be great if we had options where we could have a few more weeks to see which way the patient is going before making that decision. And there are potentially some options coming onto the market and have been around for a while as well that might give us this sort of flexibility. So again, that's another area for discussion and for further debate. But really just to summarize, again, I would commend the guidelines. I think it's a pragmatic approach, but we've got a lot of questions that remain unanswered here. I think the evidence at the moment is that a highly selective role is definitely supported and is definitely appropriate. But we really need to work together to work out which patients are going to benefit most. I will stop there. Thanks very much.
Thank you, Manj. That was an excellent summary of the literature as always, and obviously a lot to discuss, which is the point of this. While we're starting the discussion with Manj, we just launched the second poll question, which comes on from that, which is, what is the impact of Cavent, ATRACT and CAVA been on your practice regarding early thrombus removal strategies? In other words, have they changed it, not changed it, and so forth? I guess I'll put this question to Erin and Michael. Erin, you first, and then Michael Lichtenberg. You know, we have focused a lot in the trial results on what all of us who do a lot of interventions and have established practices would consider to be inadequate technical results. But that's an easy mantra to trot out if you don't like the outcomes of a trial. How much do you think, or do you believe that the technical component of this plays a role in the outcomes that we get for patients? In other words, actually delivering an open vein at the end of it. I'll go to you first, Erin, and then Michael.
Yeah, so I actually think that the the inability to assure a good technical outcome is a massive problem with these studies. And so it almost, there's something to gain from them, but it also somewhat discounts them for me. We know that inadequate technical outcomes are responsible for the majority of complications that we get referred for venous stents, whether acute or chronic. So if we don't have an open vein or we don't have the underlying lesion treated, then we can't really expect that they are going to have a good outcome at the end of the day and not develop post-thrombotic. And especially with the low stenting incidence, I think most of us that do a lot of iliofemoral DVT know that the vast majority, if not all, have some degree of some chronic component that's contributing. I think that a lot of people get FemPop DVTs from medical causes, other things, but you kind of, the flow in the iliac is so high, you have to have something underlying in order to have a DVT like that.
Thanks, Erin. Michael, your thoughts?
Yeah, I fully believe that technical success is absolutely important. But I think the discussion goes further. Technical success means in the first step to help the patient with the severe symptoms. So take the thrombus out, the patient is improved. But we all know these cases where we still have a striking inflow after a thrombectomy and not sure should we really go for stenting. And therefore, I advocate a little bit in these circumstances to wait with stenting and reschedule the patient maybe for at a later stage to go then for stenting. You help the patient immediately with thrombus removal, and if you're not sure, then go for stenting later on. Maybe this is something we could discuss.
Yeah, I mean, I think these are interesting strategies that will evolve over time, aren't they? I think there's no doubt that stenting is in its infancy as well. So those issues we're facing with in-stent stenosis, which is the same road that the coronary interventionist and the arterial interventionists have been down. The early stents had problems with restenosis, and those get solved over time. So I think there's a lot we've got to learn. The technical success seems to play a role. I think we're a little bit under time pressure after that. So we'll go to the poll results, which are really mixed, aren't they? I'm sure you can all see them on the screen that really evenly split between the first groups, apart from probably the established practices that the trials made no difference to their practice. But those wanting to start are struggling because the trials put a handbrake on progress. So, it's interesting how whatever we do in the randomized trial world struggles to change what is established, isn't it? So what we'll move on to is Erin's case, and we'll have plenty of time to go more. I'd encourage people to put their questions online, and we'll try and answer them. The faculty will answer them as we're talking. And we'll get through those. So without further ado, we'll go to Erin.
All right, thanks, Steve. So yeah, I'm gonna go through a couple cases and just a couple tips here and there, and a lot of it also is just conversation generating. The first case, 16-year-old female, she presented with significant shortness of breath and pleuritic chest pain shortly after being placed on oral contraceptives. She had no other significant medical or surgical history. She had very mild left leg swelling on presentation and really no leg pain on complaints. Her hospital workup before we were involved was a CT chest, which showed multiple bilateral PE. She had no DVT on her ultrasound. She was basically told that whatever she had must have moved already, and she had no residual thrombus in her legs. She was sent home on Lovenox with hematology follow-up, and through a friend of the family who is a colleague of mine, she was sent as a referral for a second opinion 8 days after presentation. At this point, she started to have more leg swelling. On her workup, she had an iliac ultrasound, CT scan. She had really slow flow femoral and some minor non-occlusive thrombus there at that point. She had a wide open profunda, an open distal femoral or common femoral. She was found to be positive, factor 5. Her on her iliac scan, her EIV was completely occluded, as was her common iliac vein, and you can see that it was very narrow at the top. Based on her,
sorry, I'm sorry to interrupt you. We're still, I can still see your first slide. I don't know what everyone else can see.
Oh.
You probably need to go in slideshow mode, Erin.
If you go to
I'm in slideshow. It says sharing is paused, so I'm going to do new share. Let's see. Can you see now?
Yeah, we've got you now.
Yeah.
Thank you.
Okay. So yeah, here you can see her, let me know if it happens again. Here you can see her common femoral inflow was good. Her EIV and CIV occluded. Here you can see that she's got significant compression in her cranial common iliac vein. So we did take her the following day to the operating room based on her progressing symptoms. She also was an athlete and a dancer. And this is her initial venogram. What's interesting is that none of the hospital ultrasounds found this. She clearly had progressed and she had left the hospital since she had some thrombus now in her femoral vein. But they had even imaged the common femoral and had not diagnosed this. So we went the approach of left PMT. This was not meant to be commercial, but for any of you who are not familiar, this is what I primarily use. I use a power pulse spray for delivering a lytic through the thrombus. I wait 30 to 40 minutes and then use mechanical removal, typically with the angiojet, run times less than 300. Zalante is the name for the venous version of this catheter compared to the arterial version. You know, it gives pretty effective clot removal, but I will say that I have used other devices and this, and I've not really had high success with single setting clot removal. There is some argument that angiojet may have less damage to the vessel wall. I don't know, because it doesn't have direct contact. I don't know that I've really seen any vessel wall damage with any of them. The downsides, you can have issues with renal insufficiency, hemolysis. The urine always looks like this afterwards. You can have some dysrhythmias or pancreatitis in rare cases. So, you know, you do have to be aware of the issues that can happen, but with careful technique, these are pretty limited. A day after PMT, here is her, or not day after, I'm sorry, this is still at the end of PMT. This is her initial venogram. This is her IVUS after PMT. She had a channel on her venography, but you can see here, as you're coming down from the IVC, she has occlusion under the artery, and then still pretty substantial disease. There's some slow flow in here, but there's still some thrombus as well. So I made the decision to lyse her. I do lyse most patients. I'll say that that's primarily based on, you know, if you're going to go for an open vein, then in my mind, you really want to get all of the clot out. There was a paper by Camarota quite a while ago, which, you know, nicely showed that your amount of residual thrombus correlated with the eventual SEEP and Villalta score. And here in tabular formula, you can see the same thing. So eventual SEEP and Villalta were much lower in those who had the majority of their thrombus resolved at the end of the case. So I took her for lysis. The, you know, simple advice there is to keep your upper port below the level of occlusion so that it's mostly within your thrombus and not going as systemic. Keep the lower one above the level of your sheath so it's not mixing with your heparin, which you run through the side port. I place these patients in the ICU. I typically run them at 0.5 to 1 milligram TPA per hour, depending on their size and the amount of thrombus. Check their labs Q4, which winds up Q6, and then you know, adjust from there. One of the things that comes up fairly frequently, particularly with some of my colleagues who do it differently, is which to do first. A lot of people prefer the lysis first because they don't have the OR time where they're standing around 30 to 40 minutes waiting for this. lytic to settle in place. And in theory, you could avoid some of the device-related complications if you get enough of the clot out. You don't have to use the significant run times, like for example, with angiojet. I do it the other way. In theory, you can avoid CDT in a small amount of patients. It allows for increased lytic dispersion in the clot. And for me, I feel like it's safer. When you perform, the calls that I get about docs who are having complications with angiojet, significant arrhythmias, pancreatitis, renal failure, you get that at a much lower volume with your angiojet if you do the lysis first, because your vein is already open. So you have a greater degree of circulating hemolysis, which leads to some of these complications. So this is her end result. And this, her final stent, her profunda came in right here. So this actually was a pretty good transition. It looks a little bit more tapered than it actually was. And she's back to dancing. She's now in college and a few years out doing well. Some of my tips for these cases: IVUS, I think, is extremely important. We know venography underestimates remaining thrombus. I do get patients referred in with chronic occlusions that had lysis previously, but were not appropriately stented or appropriately treated completely, so they've now re-occluded. Landing zones, making sure you're not leaving disease below. That's the #1 reason for stent occlusions and problems, making sure your inflow is okay. You don't want to use stents to gel thrombus. So if at the end of your case, you don't have a great result, lysis really is recommended. This is an example. If you use a stent to try to treat the residual thrombus, you're going to have a stent occlusion, which is now your fault, not the disease anymore. You do want to consider removal of any IVC filters if they're acutely involved after lysis. Otherwise, you can stent across them. And disease inflow, this is a patient more in that 4 to 6 week period. I think it starts to get a little dicey. She was very symptomatic. We agreed to treat her, but she had significant inflow disease already that really wasn't taken care of with lysis. She was already getting some transitional clot where it's starting to scar. So she did have some improvement, and good for her that she had a open profunda. But there is some improvement. You can try venoplasty. Afterwards, I treat these patients with aspirin and full anticoagulation. In a lot of cases, there's more than one factor when they get a DVT this big. So it's not just a May-Thurner lesion. Sometimes it's May-Thurner plus car ride plus OCPs, but a lot of times they also have an underlying clotting disorder. If they have reasons for long-term anticoagulation, such as thrombophilias, complex stent configurations, permanently damaged inflow where the femoral vein is scarred, then I do tend to leave them on long-term anticoagulation. Frequent follow-up with duplex to monitor their stents and their outcomes. And then the other cases I kind of threw in here, just a slide or two each to show some other examples. This is a 51-year-old pharmacist, history of unprovoked left clot. He actually had lysis and venoplasty, but he was not treated with a stent. They felt that he didn't need one based on his venography. He presented with an acute right leg DVT, so the opposite leg. And he had admitted to some chronic left leg swelling, which he managed with compression. He had some hyperpigmentation circumferentially in his left calf. His ultrasound showed acute right DVT, as well as a left common iliac occlusion and some stenosis below it. So here are his pictures. This is his initial scan, venogram, and you can see after lysis, you can see what really was chronic and untreated from his prior disease. And this is some of the concern with these trials, that where they're not stenting or they're not using IVUS. They were pretty adamant they had gotten everything out, but all this is chronic, and it's actually now impeding on the distal IVC and affecting the other side. This is him after his stenting. This one, I think it's 49-year-old male, bilateral iliac stents previously, and he presented with acute leg pain. And his showed a right stent occlusion and a patent left stent, but that the left stent was jailing his right CIV. This is another case that I treat fairly often. Here you can see this Y configuration of old stents with a occluded stent on the right. This is a different patient, but I put it in here just to comment because I get this question actually a bit about whether I think this will happen with the newer stents. And yes, we've already seen it. I've seen it with 2 of the 4 new stents so far, and the 2 that are currently available on the market. So this is not unique to wall stents or to closed cell stents. I think about it just like our filters. Our filters occlude and they've got big, openings on them too. Here's the patient after lysis. This is patient's now prone. And then here, same thing after lysis. And so in order to get, you can see there's still not flow here, and that's because that channel at the top where the stent jails over becomes kind of closed with intimal tissue, so it won't lyse open at the top. It actually takes a minute to get through it. And then the way to get flow restored is to make a fenestration through and restore flow without jailing the opposite leg. And then this one is just to generate discussion. I don't have any procedural slides for him, but I will say that, we keep saying at all these meetings, oh yeah, we selectively treat iliofemoral, oh, but ATTRACT has convinced me not to treat FemPop. I see 1 to 2 patients a month with chronic post-thrombotic disease from occluded popliteal veins and occluded FemPop segments. Now, this particular guy was not treated and he's only, 8 weeks out, but his leg, it's hard to, you can see it a little bit on the left side, is more swollen and still erythematous compared to the right. He's actually on Lovenox, and he has an occluded FemPop segment. He has no iliac component. So I don't know. I'm curious what everybody does with their FemPops, because I don't know what to tell these patients that come in, and I think the number needed to treat is very high to help these patients, but I do think that there's something to them that we have to figure out, because just telling them, well, 20 of you won't get it, so we don't bother to treat is a hard pill to swallow. These guys, this guy's on his feet 10 hours a day. So yeah, thanks everybody, and any comments are appreciated.
Erin, that's excellent. Thank you. Thank you very much. We'll come back to that FemPop in a minute. Can I just let the audience know, if you've got questions, the easiest way to do it is to just type them into the Q&A section. The panel will try and answer them as we go along, but it sometimes gets a bit carnage if you all just put your hands up. It's difficult to manage. So Erin, should we put that back to the panel then? So what are all of your thoughts on these FemPop segments with these residual symptoms?
Yeah, well, I agree with Erin. I think, it's kind of to the point that Manj made earlier. We've got a long way to go in understanding who to treat and when to treat. But people get really debilitating PTS. And I think what we keep forgetting about PTS is, in medicine and everything, we focus on death and amputation and so on as hard outpoints. PTS, moderate or severe, is a life-destroying illness with comparable quality of life to chronic diseases of other kinds, where people lose their job, can't work, can't do anything, can't exercise, can't do stuff with their kids that we all take for granted. So I think we've got to get better at understanding it, but that also comes with the improvement in techniques. Like all things, stroke, for example. Using thrombectomy or embolectomy techniques for treating stroke was heresy for many years, until the technology caught up, the techniques caught up, and it now is undoubtedly the gold standard for stroke and try and deliver it quickly. But our basic physiology understanding is even poor. So we got a ways to go, but there are definitely patients who do really badly with FemPop disease. But working that one out is even more difficult than the iliofems, where I think it's much clearer, who you're going to choose right at the very beginning to treat.
I agree entirely with that comment, Steve. It's one of my most troublesome, in a nice way, patients with PTS has got a FemPop occlusion. And I suppose that's not the question. ATTRACT showed us that a lot of these people do get significant PTS. The question is, does intervening on them create benefit or not? That's the question. And the ATTRACT subgroup analysis showed categorically that that wasn't the case and there was more harm. If we can select the people better, then of course we can change that benefit. But I think it's going to be difficult in my mind to justify aggressive treatment for these patients. You get one bleed, one complication, you can just imagine what the UK laws are going to do, let alone the guys in the US. I mean, it's a very difficult area.
Yeah, but I think that's where just, you know, where the bleeding risk is tied to the lytic use. And Michael's going to talk about that soon. And I think that answers some of the questions. Lytic dose is completely correlated to bleeding. And as we get better with better techniques, with lower lytic, and the devices have improved markedly, because we are now getting devices designed for the venous system rather than trying to make do with something that was made for arteries or made for in most cases, made for the cerebral circulation that just got made 6 times bigger to suck stuff out of veins. It wasn't the right way to approach it. So I think we'll see if you are using lytic-free devices that clear clots in single sessions, and then you get somebody fully anticoagulated and you've decompressed the whole leg, I think they do better. And I think that comes back to your patient, why she may have been better off, because you've decompressed that initial swelling. You've then got a kind of almost controlled rethrombosis with less of the inflammatory response and less of everything else going on. Sometimes I think that does make a difference, but you know, that's controversial, I accept. Do we have another poll, Chris? I think we do.
I was about to say, should we launch the next poll while we're just talking about this? So I think the last thing that's come up a couple of times is you guys stenting. And some of the cases look different to the others. So there's been this trend towards stenting a lot more, especially with the use of IVUS and the sort of recognition that you can see exactly what's going on better on IVUS than not. What are your guys' practice now? I mean, are you, because Manj, some of your cases, I don't know if they were early cases, had relatively shorter stents. Is the trend now with all of you towards stenting much longer lengths of disease, especially looking at the inflow as well?
Yeah, I mean, in general, you've got to stent from good vein to good vein. And I don't think any of us would ever use a very short common iliac stent only. I think those are the ones that get into trouble. So the shortest stents that I would use would extend into the external iliac. So 12 or 15 centimeters, depending on which brand you're using. So to really fix it in that external iliac.
Especially with the issues with migration that have happened as well. You know, I think you've got to come around that corner, haven't you, and fix it there so that they're not flying off and going elsewhere.
Yes, I agree with that. I think, Chris, what we've learned is, again, arteries are not veins or vice versa. And in venous disease, if you select the right patients and you're getting ready, and, you know, Manj's graph earlier on showed that patients with more severe symptoms at presentation are more likely to go on to get PTS and are the ones who benefit in the ATRAC study. And that was one of the problems with ATRAC, was the equipoise. A lot of patients ended up getting enrolled. 1 in 51 patients screened ended up in the study, and there were additional patients who weren't even considered for it because they refused because they had such severe symptoms. But your severity of symptoms at presentation is a strong indicator of how you're going to do. We've all seen those patients that come in with an extensive left femoral DVT but are walking fine, their legs a bit swollen, but they're okay. I mean, we would leave those alone. We don't treat those in our practice. But if you select that group out, they almost invariably have some form of underlying iliofemoral disease, which has taken the whole system down. And you know, you kind of end up stenting that, but you have to stent from good to good. So it's a different approach to stenting to what you get from arteries. That's great.
That's great. Thank you very much. So I think the poll, the next poll has ended here. This is obviously about this too. Following successful DVT thrombolysis, how do you treat any underlying iliac vein stenosis? And a reasonable majority say do a venous stent immediately, but there's still 30% there saying it depends on the patient, which is interesting. So maybe that's something, Michael, you can bring up when you're starting your talks now. But we should hand over to you and let you start presenting your cases, please.
Yeah, thank you very much. Thank you very much for the invitation today. It's a pleasure to be here. And yeah, I'm sorry, I'm coming from a very conservative country, I must admit. Yeah, so I would say only 3 of 10 patients are treated interventionally for acute DVT. So I would like to take this discussion and maybe bring us some more arguments how we can treat patients with acute DVT safe and more effective. Disclosures. So already mentioned this ATTRACT study itself was not very helpful. It's one of the main reasons why a lot of conservative colleagues in Germany now advocate for conservative treatment, especially in terms of efficacy and complications like bleeding complications. So we have to take this discussion, and when we have a look at the subgroup analysis of ATTRACT published by Moderators, we definitely find answers. And Manj already mentioned it. The correct indication, I think, is the way to go. And when we only treat patients with acute descending ill femoral DVT, then we achieve a good success within these patients, and we treat them safe. But of course, the safety aspect is something we should highlight more, and bleeding complication is something we definitely need to discuss. When we learned from example, the Carbon trial, that bleeding complications with CDT was up to 20% major bleeding complication. So how can we improve here? And therefore, I believe pure mechanical thrombectomy is the way we should go in the future, and maybe there are data for that. And we recently analyzed this within a meta-analysis which we published last year, where we compared efficacy and safety within a meta-analysis and in terms of efficacy and safety. So for that, we analyzed publications between 1946 and 2018 in terms of efficacy endpoints and of course of safety endpoints. And we included here methods in the studies like thrombolysis, especially CDT or ultrasound accelerated CDT, and compared this with percutaneous mechanical thrombectomy, including all the existing so far systems like angiojet, angiojet plus direct stent, angiojet plus CDT, or stage stent. I would like to show you here the included literature for this meta-analysis. We included 19 studies. 7 of these studies were randomized controlled, 12 of them were observational studies. Here are some of the endpoint analysis we made here. We focused, as said, on efficacy endpoint, and I think one of the most important is lysis grade 2 or 3. When we compare these both groups, CDT and PMT, we can clearly see here within this meta-analysis, there was no difference in terms of that endpoint. So CDT and PMT are both efficient in terms of lysis grade 2 and 3. The overall PTS rates between CDT and PMT is shown here. We also found no significant difference for the endpoint PTS, as you could see here. And this also counted for the endpoint moderate or severe PTS, even including the subgroup analysis of ATTRACT by Moderators, no significant difference in this efficacy endpoint. But we found a highly significant difference in terms of safety for major bleeding complication endpoint. This safety analysis clearly showed that PMT is much safer than CDT therapy. So in summary from this meta-analysis, the real advantage for PMT is safety, significant lower bleeding complications, and there was even a trend towards lower pulmonary embolism. In terms of efficacy, no big difference between PMT and CDT. So therefore, I personally advocate to stop CDT, as we have good and efficient PMT, which is much safer than CDT therapy. And we have now very good new devices. I would like to show you some of the new devices. We're also here in this Ravine catheter, Steve Black and Gary O'Sullivan were involved. We were able to analyze the Ravine catheter from VTEX Medical and learned about this catheter. And the most important aspect of all these new techniques, these new techniques can address the organized material. And the organized material is that why we have to give so much high doses of CDT. And this is not any longer needed with the new devices. Here you see a typical case example in a 21-year-old female patient with a descending ill femoral DVT, which we treated with the Ravine catheter. Typical descending ill femoral Maythorn-associated DVT with the occlusion of the FEMPOP. Also, we did a popliteal approach here and treated this young lady with the Ravine catheter, which is a French device running over an 018 guide wire. Here you can see in the next slide how the catheter is pulled back through the obstruction. You can see the compression of the cage at the tip of this catheter, compressed in the May-Thurner syndrome. Yeah. And then the cage opens again, and this cage is able to remove the wall adherent organized material from the wall, and the acumatic screw within the catheter then captures fresh thrombus and also the organized wall adherent material. And this was the outcome after the first run. As you could see here, we did a second and third run in this patient, of course. And afterwards, we had a very good outcome, as you could see here on this slide here. Very good inflow, very good outflow, no more residual thrombosis, no thrombolytics were needed. Valvular function, very good after thrombectomy, and there was a significant reduction in Walter score and VCSS after 4 weeks. So therefore, I would like to advocate that with these new techniques, we are safe and efficient, and we don't need any CDT. And the aspect of this organized material, I think this is a very important one, because this forces us to use CDT for 24 hours, 36 hours to really clear the vein. And there's more now, there are more techniques now in Europe available. The already very well-known clot retriever device in the United States for a couple of years now, well-known, has come now also to Europe and also to Germany. And we were able to already use this device 7-8 times here. I would like to show you a case here and then subacute DVT. So this is a patient, 3 weeks of pain. We tried this device, and this is our very first case where we use the device in a very subacute setting with very organized material, as you can see here. And we filmed here this approach during a live case transmission. You can see here that the mechanism of this clot retriever is a huge basket above the thrombus, which is then pulled back so that the whole thrombus within the iliofemoral tract is cut in this large bag and then pulled out through a 13 French sheath outside the body. And with that, we treated here this 3-4 weeks old DVT in this lady with massive swelling and a lot of pain. And in the next video here, you can see this is after the first run already with some flow. And on the left side, you can see how we cleared the basket here, where all this organized material, the fresh material, was stuck here in this basket. And it was very efficient to see actually how much organized material this system could get out even after first pull back here within the iliofemoral tract. And at the end, after a second passage, we were already so far that we could stand the underlying May-Thurner syndrome, as you could see here, and finish the case here with dedicated venous stent implantation. No additional lytic therapy was needed. We could treat the organized material, and we could help this patient immediately and resolve the pain. And there are also different other devices available. I just want to mention the JEDI Walk vascular thrombectomy system, which also can address some of the organized material. And this is just to show you how effective this system is in an acute DVT here in a patient with descending iliofemoral DVT here. Actually, we stick into the anterior tip vein, very fresh thrombus. You could see here fresh thrombus in the area and the whole iliac tract proximal. And here we use the 8 French JEDI system, and I just want to show you how effective the system is in removal of this fresh thrombus in the FEMPOP area. And you could see here now in a second how this catheter sucks out this contrast infiltrated thrombus very easily, just with one approach. And I think this is another proof of concept for these new devices, that with that we can treat very safely and efficient patients with acute DVT. No need for additional CDT. There's no need for actually sending this patient onto the ICU. We could even send this patient 2 weeks later. You see this efficient way of how this JEDI system really sucks out this contrast-filled thrombi here with approach. Usually I do this without a guide wire, just activating the system, going forward, and let the system work, and very forward, backward movement of that. You can suck out this thrombus here in this fem pop area of this patient with the acute DVT. So in conclusion, from my experience and our experience, mechanical thrombectomy and venous occlusion is very effective in removal of acute, subacute, and importantly, chronic venous thrombus with these new devices. It restores vein patency, not only in the lower limb, also not shown here, but very often performed now in the upper limb. It preserves valvular function, has low risk and less side effects than thrombolytic therapy, and this is my absolutely key message here. There's no need for ICU stay and not for a prolonged CDT drip. So we could end these procedures in the angio lab, and with the early thrombus removal, we may prevent, and I think this is our goal, the risk of post-thrombotic syndrome. Thank you very much.
Thank you, Michael. That's a fantastic summary of that. I know you need to go back to work soon because you've got cases in your emergency lab. So just a question for you that you can perhaps address, and we'll go to the rest of the panel for the remainder, and you can get to what you need to get to, saving lives, which is more important. Do you think that the PMT devices, as your data and others start to show, are going to start to take over from lytic-based devices, even the middle ground like angiojet and so on, where there's a bit of mixture of both, and we'll see lytic becoming less and less commonly used?
So from my perspective, I definitely believe that PMT will definitely change the world. And I even believe that combination therapy, so meaning pharmacomechanical combination therapy, will at one point not be needed, as we have so much mechanical thrombectomy devices now available, like the Revene catheter, as it showed from VTEX, or the clot retrieval device. And I think the key important point here is that these new devices can treat even this organized material. And I think this is the important aspect. These first catheters, also including Arnsbergs, they really can't really treat this organized material. And then we are forced to give CDT for a longer time. And then we are back to the old discussion. And therefore, I think investing in these new techniques maybe bring us away definitely from CDT therapy.
Yeah, I mean, I think that's a good comment about CDT for a longer time. I think it's probably because of a lack of understanding, isn't it? Because once CDT or whatever you use only works against thrombin, and once you start to lose thrombin and you start depositing collagen and organizing that material, there is nothing for CDT to work against. So in some respects, this sort of running CDT for longer when it doesn't work is probably a sort of thing we need to get over anyway, because it's not actually going to make a difference. It just gives the patients more risk. Michael, thank you so much. I know you've got to disappear. I think we've got another poll which we'll put up in the meantime. While we're doing that, Erin, you in the US have had exposure to some of these newer devices, the clot retriever in particular. What are your thoughts with that, and where do you see that fitting in with what we have at the moment?
Yeah, so I don't really think that this we've been chatting about, but I don't really think that they have a big role in chronic, which I think they're being marketed for. I think that they're using the incorrect terminology. I think that maybe they have a role in some of these more mechanical ones in the subacute, that angiojet and the lytics are not going to be as good at getting out. They may be able to get out more components of that. And I think that's the period that they really mean in that 6 to 8 week window. But a lot of times my hesitancy in that group, though, when they start to have clot transitioning from the acute to chronic phase and you're not really in either, is if you get the clot out, what's your inflow look like? You know, like I showed that, that slide where the inflow is already starting to scar in at that 4 to 6 week period. So, you know, whether or not there's going to be a niche spot for some of those, maybe, but I haven't been overly impressed with my small handful of cases that I've done.
That's great. Thanks, Erin. So we got this poll up here about history of malignancy and acute symptomatic ephemeral DVT, and that's an interesting and pretty, apart from saying never offer it, everybody else is pretty much split between the different strategies with the stage and survival narrowly nudging ahead of the other two, but fairly well spread between those other three options. I think Jerry O'Sullivan in Galway probably has a really big experience of treating cancer patients, where the majority of their population comes from, and I personally think it's not an unreasonable palliative option to offer patients who have got a really badly swollen leg from malignancy, who are otherwise going to lead a pretty miserable existence for their last few months of their life. And I think it does help to get patients home, allow them to manage the last few months with some degree of dignity. What you do have to worry about is the anticoagulation strategies, and it's interesting with malignancy patients, if the DOACs are now licensed for use in them, which is helpful. But if you are using low molecular weight heparin, we found that measuring factor 10A levels is very helpful, because oftentimes a patient with a really active malignancy needs a lot higher dosing than you think to get the anticoagulation levels to a stable place. So in big patients and patients with cancers, it's useful to have a really good involvement with your hematologist to make sure you get the anticoagulation spot on, which is almost as important as the technical aspects of stenting, which is what we almost seem to discuss all the time, rather than all the bits that go around it. But I think that leads us into Hayley's talks, if we're going to try and keep even vaguely on time, which are two cases with a slightly more chronic element to them. So Hayley, take us away.
Thank you very much, and thank you for the opportunity and the invitation to speak here today. Hopefully that's screen sharing there. So I'll launch straight in to a couple of patients. One is more of a decision-making process, and the other takes us through the whole treatment option. So these are both patients that I've seen very recently. So the first is a 14-year-old boy who was referred up from a unit just outside of London with a week's history of left leg swelling. Trying to question him was a bit of a challenge. There was a lot of swearing and stomping around the clinic room, and he actually left clinic and refused to come back. But his mum wanted to talk some more, as she was very keen in having some sort of intervention. On further questioning, although his left leg swelling had occurred only a week ago, as Manj mentioned earlier, he'd had that back pain, that sort of classic lower back pain, couldn't get comfortable really for about a month. No right leg symptoms, interestingly. For him, no history of deep vein thrombosis, but he was born at 28 weeks and underwent cardiac surgery for VSD via thoracotomy, and spent the next 12 weeks in the special care baby unit. And his mum did report that he had lines in the groins and so on at that time. He also had attention deficit hyperactivity disorder and a history of self-harm. And this is his MR venogram here, non-contrast acquisition. The suprahepatic IVC was patent. The infrarenal segments of the IVC showed a high-grade stenosis, and you can see that there are hypertrophied azygous and hemiazygous veins. On the right leg, so this is his asymptomatic leg, there's a high-grade stenosis of the common iliac vein, but the external and inferiorly to that were all of normal caliber and appearance. And on the left leg, you can see there that there's acute thrombus within the common iliac, external iliac, common femoral and deep femoral veins there. And further down also the popliteal was occluded, and that was confirmed on the duplex as well. So I think this is a patient that we're seeing increasingly frequently now, and as much as I think we've got to look at the long-term potential beneficial outcomes for a young patient like this in terms of reducing their post-thrombotic syndrome. I had quite a lengthy conversation with his mum, and unfortunately I couldn't examine him more thoroughly, but you know, I could see just observing him walk down the corridor that he really did have a significant limp still, and his leg remained very swollen, and this is certainly a week down the line from the leg swelling, but in reality probably a month from when he started to form clot there. And of course what's clear from the MR venogram is that chronically, probably as a result of his the lines that he had in the groins as a child, and that time of his life, then he's got chronic scarring of the IVC. And I think this is one of those interesting patients where, as much as you'd love to intervene, I think first and foremost we have to do no harm. And I felt that this patient was at significant risk of just pulling everything out. You know, we can't keep him under general anesthetic for CDT for several days, and you know, the pharmacomechanical thrombectomy options are not for these more chronic patients aren't necessarily the right thing. And you know, he's at risk of just jumping up and pulling everything out and making a dash off the ward. So I think this is just to highlight, don't just look at the scans, think about the patient. Are they actually going to tolerate having these procedures? Think about the ward staff as well, and how they're going to be managed, and do no harm. I don't know what everybody else, I was hoping these cases would stimulate a bit of discussion, and I don't know what everybody else's thoughts are on the panel about that type of patient.
We'll have the discussions at the end, Hayley. We'll come back to them. So just show us the next one. We can.
Okay, so the next one is a 27-year-old gentleman. He'd had catheter-directed thrombolysis for bilateral iliofemoral DVT 7 years earlier. He'd just had 6 months of anticoagulation and then stopped. He did recall at that time that it was mentioned to him that his IVC was completely occluded, but he didn't undergo any subsequent procedure. On direct questioning, his right leg was not as good as the left for the last 7 years. It would be the one that troubled him when he was up on his feet all day, every day. Worse at the end of the day. Venous claudication, actually at relatively short distances, although he did persevere, and his, you know, just redness of the skin, plethoric leg. He presented again with a 7-day history of right leg swelling, and he had a duplex and MRV, and the decision was made to proceed with thrombolysis. So at that time there was ultrasound guided bilateral femoral ultrasound guided right femoral vein punctures. You can see this patient is in the prone position. It demonstrated that there was an occlusion of the femoral vein, and then, as you can see also there, the chronic occlusion and collaterals of the iliac vein system as well. So thrombolysis was started. This is the check thrombolysis, so this is after 24 hours of thrombolysis. And you can see here that there is clearance of the femoral vein to the level of the lesser trochanter coming up here, but no recanalization of the patient's iliac vein system. The next day, I haven't showed the images because it's basically completely unchanged. So after 72 hours of thrombolysis, this is what the patient looked like. Again, the femoral vein is patent now. The common femoral vein looks better, but again, the iliac system remains occluded. As we've already discussed, the last 24 hours, the patient dropped their fibrinogen levels and had to have a couple of pools of cryoprecipitate. So lysis was stopped. And the question is, what next? So discussion with the patient regarding his symptoms, discussion that his IVC was occluded, his femoral veins were occluded. Probably in that first lysis stage, a lot of he had some improvement in his symptoms, and sufficient collaterals were probably opened up for some symptomatic relief. But this moves on to the question to proceed to stent or not to stent. The patient, based on the fact that he'd had venous claudication and ongoing symptoms after his previous presentation, after counselling on the risks and the follow-up and the anticoagulation, decided to proceed with an IVC reconstruction. What was interesting was after cannulation on the right, you can see that the femoral vein, and that was in a period of 24 hours only, had already reoccluded. And you can see that here as well. So angiojet device was used to clear again that femoral vein, which was at that point a very acute clot. And that was successful then in restoring the femoral and subsequently common femoral veins. Interestingly, on the left side, the common femoral and iliac veins were actually patent, and this was the side that he'd actually had relatively good symptom relief from since the first procedure as well. That was his good one. So the IVUS, as you can see, the coming from both above, from the right internal jugular and below, the lesion was crossed on the right side, and this is the patient's IVUS on the right. You can see there that there's a tight stenosis all the way through the iliac vein segment and into the IVC. The proximal and distal landing zones were then marked. An Atlas gold balloon was used to venoplasty, pre-dilate the right side. And then the approach was made from the left to meet the right and cross over into the patient's IVC. And the balloon technique inflated there was used to cross over the septa that are there. Always important to do a lateral view. Make sure you are where you think you are. The wire was snared to allow a through and through wire, and position was confirmed. And then the IVC reconstruction commenced with pre-dilatation on the right side, and then a Sinus XL stent was used and deployed in the IVC. And this is the IVUS on the left side. Following on from the stent. And you can see there, the stents are widely patent. There's good inflow and good outflow. On those images. Oh, sorry. And then the procedure was completed. This shows the remaining post-dilatation of the stents IVUS again then to mark the inflow on the right side, and Abre stents were deployed. And post-dilated. And then the venograms demonstrate loss of most of the collaterals. And you can see here on the IVUS that post-dilatation, again, good inflow. The stents are nicely expanded and good outflow. The patient's subsequent duplex scan has shown that there's just some minor stenoses, 10–20% only. There's good inflow, good outflow. The patient's had excellent symptomatic relief from this procedure and is just pending CT and discharge. So those were just some cases to highlight those patients that certainly the first one presented with what was apparently an acute DVT, but there was a chronic element. The second one, we already knew from the history that there was a chronic element. And I just wanted to open that out to the panel to discuss about what their thoughts are regarding, it opens up the question about proceeding directly to stenting and treating the underlying chronic disease as well at the same time.
Thank you, Hayley. That's fantastic. I think those are quite varied cases we've had from all the panel over time, and I think the last case in particular is something that a lot of us wrestle with IVC. When you get somebody who's clearly had some sort of pediatric injury or potentially IVC atresia, and they present quite typically in their late 20s, early 20s, rather late teens, with acute thrombotic events. If you restore them to what they were like before, i.e. you reopen all the good collaterals, do you need to go for stenting? And Erin, what is your approach to that sort of case in your practice? If you do see, because clearly you had a successful 7 years from that the first time round, so this is, it doesn't seem to be always that you need to go immediately to stent.
Yeah, so you're right. The lysis will probably get him back to where he was to start with. And in those cases, I actually do prefer lysis to just a single setting, because you're going to open up those collaterals better that he had before. However, in my experience, I do generally proceed directly to stenting. I think that patient remains at risk for this happening again. They've basically just told you that they're, at risk for distal DVT. And if you wait, you probably can get away with waiting if you keep them on Lovenox and there's some reason to wait. So you're waiting for more, their inflow to develop better or something. But frankly, they need a stent anyways, so I wouldn't give them that risk period of waiting to get another DVT.
And what's really interesting is that patient, although he never came back, he never represented to secondary care to say he was having a problem with his leg. It was only when you really hammered him and said, what's been happening with your leg since? Oh, well, yeah, actually, I can't walk very far. Oh, I don't do my sporting activities. It's all of those things that, these patients just sit and learn to live with it, don't they? Because that's what they think is their new normal, to use a phrase that we hear a lot at the moment. And I think that's an interesting thing. If you actually go out and ask them, they have got ongoing symptoms.
Yeah, I mean, I think
a very quick comment, if I may, about the first case, Hayley. So I think the point you raised, which is really important, is these younger patients, even if they're physically developed, emotionally, the process for going through lysis, thrombus removal, whatever it may be, it's a very emotionally exhausting process for them. And I think we've just got to remember that even if they're physically developed, these teenage younger patients, it's a big deal. And compliance and surveillance and all of these things are obviously big factors.
Yeah, I think it's difficult. I mean, there's an emotional response to somebody being 18 or 14 or 16 that is different to somebody being 20, right? So we do get sometimes a little bit caught up in age in a different way, but it's having that network and support around them. There is absolute evidence that patients in their teens and who are younger, who develop a blood clot are at much higher risk of recurrence, and they're at much higher risk, therefore, of PTS in the long run. And what component of outflow obstruction plays a risk in their recurrence is quite hard to quantify, because we don't have good epidemiological data about that. I mean, if you look at the pregnant female population who get DVT, virtually every single thing that everybody thought that may be the cause of their DVT has now been eliminated. And the last thing we're left with is flow and iliac outflow obstruction being the most likely culprit. So as we get to understand the epidemiology more, we're probably going to be able to start finessing some of these patient decisions in a better fashion. Manj, I guess the question with all of this is, we've come back to this a few times, and a few people have asked questions about the outcome measures and the outcome tools that we have available to us at the moment, and trying to combine better outcome measures, patient-reported outcome measures, and so forth. What is your thoughts on where we stand with how we're measuring outcomes in venous treatment? Are we close, far off? How much more work do we need?
So there's no magic answer. There's no single outcome measure that is going to be the thing that everyone should measure that's going to answer all the questions. The reality at the moment is that we need to be measuring a selection of things. Clearly, you need anatomical outcome measures. You need to be reliably informed that your intervention has dealt with the anatomical problem. There's got to be something patient reported. VANES qual-sim is probably the most validated disease-specific quality of life. Villalta is a bit of a swear word for some people. It's also the most validated outcome measure that we have, probably, for PTS. And whatever we like or dislike about it, there's so much published about it, it's probably difficult not to measure Villalta. So I think at the moment combination, but new patient-reported measures are desperately needed for this group.
Yeah, I think that's right. Although it's quite a difficult task, isn't it? There's no simple way of getting new validated tools. I think what we've learned from the pelvic congestion group is it's taken them 2 years just to come up with a CAP equivalent for pelvic vein congestion. So outcome measures are a lifetime's work in many respects, which is frustrating. I think we kind of close to time. I don't know if we want to give everybody on the panel an opportunity to make something that they think everybody from here should take home with them about treating acute DVT and managing these patients. We can start with you, Manj, and go in order of speakers: Manj, then Erin, then Hayley. We've lost Michael, and then I'll hand over to Chris to sum up.
Yeah, very quick 2 points from me. Patient selection for me is the absolute key. If we get that right, then the how is probably less relevant. Having said that, the new thrombectomy alone techniques are very exciting. So patient selection and then the new thrombectomy techniques are the real take-homes and the exciting areas for me.
Erin?
Yeah, so I would say to not discount treating these patients and really look at the patient in front of you and don't discount them just because of some of these trials. I don't think they necessarily represent the patient. And then the next thing I'd say is really learn and continue to perfect your technique for these patients, and do the best you possibly can to get the best results.
I would say good patient counselling about what they've got and what's coming, depending on what the procedure that you do, so that they're engaged in their own decision making, and don't lose your inflow or risk you losing your inflow.
Yeah, okay, those are two great points. I think I would echo a little bit of what everybody said. Acute DVT treatment is an endlessly. There's no doubt that certain patients benefit fantastically well from good treatment, but the point is good treatment. Like everything we do, if you're an aneurysm surgeon, or you're a PAD surgeon, or you're a venous surgeon, or whatever flavor of vascular surgery you're embracing, the point is that good surgery gives good results. Bad surgery from bad technique or bad efforts has poor outcomes, whatever field we go into. And so venous may have less tangible downside in terms of death and limb loss from bad technique, but it still has tangible downside. So focus on your technique, go and learn about it, spend some time getting it right, and then focus on the added things we don't really talk about. Get your anticoagulation strategies right, get stockings in your patients, make sure you have a good duplex surveillance program, have a team of people. All those other things that help success or that give your patients good outcomes. Those are the things that build a good practice and give you satisfaction when you treat people well. So with that, I'll hand over to Chris to summarize and whatever.
Thanks very much, Steve. So look, so it's just a summary now. So on behalf of BSET, who've organised this, thank you all so much to the faculty for spending the time to sort this out and then coming along on a Saturday. Steve, thank you for coming and agreeing to chair it as well. And then the final thing is just to plug the conference again and say we've got the conference coming up on the 24th of June for the afternoon. The BSET conference is going to be a really good action-packed afternoon, so I'd encourage everyone to come along to that if they can. In terms of feedback and your CPD, that will come via email for all the participants. So look out for that. That should come out soon. You can just reply to that, sort that out, and you can give us feedback on the webinar, and also you can get your CPD points sorted via email. So thanks again to everyone that's come along, faculty and participants. Thank you.
Thank you.
Thanks all. That was excellent. I think that ran really well.
Yeah, I think we still probably got people on still live. Thank you to everybody for participating. The best way to end this is to end this. Otherwise, we all stay live for the next 2 hours. So enjoy your Saturdays. Thanks, Chris. That was fabulous. Thank you so much.
Bye-bye.